Hello, welcome back. I'm Dr. Mark, and today we have our second part of our neuropathic diabetes video. Today we're going to review diagnosis, treatment, and a little bit about the types of subtypes of diabetic neuropathy. So let's check this out. So as we said in the previous video, diabetic neuropathy is a disease of the peripheral nerves, and we have three main types: sensitive, autonomic, and motor neuropathy. And each of these types of neuropathy will have very specific manifestations. First of all, if we see sensitive neuropathy, we're going to find distal symmetrical polyneuropathy. This means that we are going to find this neuropathy in the furthest parts of our body. So it will probably start in our toes, then our feet, and then our legs, and finally in other distal parts like our hands. It is going to often be symmetrical, so if we find it in one foot, we should find it in the other foot, because of course hyperglycemia, that is the main thing causing this damage to our nerves, is everywhere in our body. So both of our feet have the same level of glucose and thus the same level of nerve damage, and it's going to be polyneuropathy. So we are going to find a sensitive neuropathy, but we are also going to find many sensitive nerves and other types of nerves affected at the same time. This is the meaning of distal symmetrical polyneuropathy. It's the most common type. There are some patients that we might find a non-symmetrical polyneuropathy, so a patient that maybe has a lesion in one of their foot might have a more severe neuropathy in that foot, in the previously affected foot, and thus it doesn't look symmetrical because once again the nerve was already damaged in one of the foot, for example. However, most patients it is going to be symmetrical. Number two, the most frequent distribution is stocking and glove distribution. So as I was saying, first the toes, then the feet, then like stockings, and finally we add the hands. Of course, it can progress further, so we might find a sensitive neuropathy on all of the arms, all of the legs, and once again, if there is some other part of our body with previous neuropathy, for example, a patient whose sciatic nerve is already damaged, that has sciatic pain, might have a much more severe sciatic pain because of the previous sciatic nerve affectation, but also because of the hyperglycemia. So these two things work in tandem to damage that nerve, that specific nerve, and that patient might present even before the toe alterations with a sciatic nerve pain. And of course, 30 to 50% of patients will have neuropathic pain. So we might start not with pain, but with very strange sensations called dysesthesia. So we might find like the patient feels droplets of cold water or just cold, feeling very, very cold, even inside, like the bones. Many patients, when they arrive to the clinic for the first time, they tell us, the thing is, I feel a very, very cold bones in my feet, in my legs, or on the other hand, a very hot feet and legs. So it might not start as pain, but it starts like a strange sensation, then a uncomfortable strange sensation, and finally the patient develops pain. And once again, 30 to 50% of patients will have pain that can be severe and highly disabling. Now, on top of these sensitive alterations, we might also remember that we have some nerves that sense the position of our body. These are called proprioceptors. These are super important for coordination and walking. So there are some patients that might not experience so much sensations, like something walking on the foot, cold, hot, and so on, but they might not be able to walk, because once again the brain no longer knows the position of our feet, and thus it gets confused and the patient might stumble a lot. So that is another important manifestation of sensitive neuropathy associated with hyperglycemia and diabetes. In second place, we have autonomic neuropathy. These are all of the nerves that reach our internal organs, and of course they tell these internal organs to work at a certain pace. So when the nerve is affected, the organ is also affected. In the case of the heart, it's very obvious what it will happen. The clinical medical term is autonomic cardiac neuropathy, and this patient might experience weakness, dyspnea, orthostatic hypotension. So when the patient stands up, it gets really dizzy because the heart doesn't compensate for the new position, and thus the blood is not reaching our brain. Dizziness and syncope, patient that spontaneously becomes unconscious, it basically faints. Tachy or bradycardia, so a heart that is very fast or very slow when it shouldn't be. So, for example, a patient that starts exercising and then the heart, instead of increasing the pace, it reduces the pace, and we have bradycardia. And of course, this all leads to exercise intolerance. Fortunately, autonomic neuropathy is not the first manifestation. We usually find first sensitive neuropathy, and then we are going to start with autonomic neuropathy. Gastrointestinal, we find gastroparesis as one of the main findings in neuropathy with these patients. This means that the stomach is not moving as it should. So usually the stomach moves a little bit, then we eat, it moves a lot, it processes the food that we ate, it sends it to the intestines, and then once again it stops working so much. So in these patients, the stomach just doesn't work, doesn't move, doesn't process the food, and thus the patient feels nausea, appetite changes, especially in elderly patients. They stop eating and they start losing weight, but in an unhealthy manner. Distended abdomen, dysphagia, this means that the patient has a hard time swallowing the food, and once again it difficults proper eating, and the patients, even a diabetic patient, needs a very strict diet and eat in certain hours, certain things, and all of those things. And finally, vomiting. They might also experience low intestinal motility and constipation, or even diarrhea, very hard to treat diarrhea. We can also find this in the bladder with diabetic cystopathy, leading to urinary incontinence, so the patient no longer controls when he or she is peeing, basically, or urinary retention, so they can't pee, and this leads to severe problems, having to go to the hospital to have the bladder basically emptied. And urgency, a patient that is sitting like really relaxed, and then suddenly a very severe sensation of needing to pee. Sexual dysfunction with impotence, dryness, and low sex drive, and alterations in the skin with sweat autonomic dysfunction, leading to severe skin dryness. This, once again, this dryness may appear anywhere, but it's usually even more severe in distal parts of our bodies. And finally, after autonomic neuropathy, we may find motor neuropathy. And this motor neuropathy is, of course, the alteration of the nerves that lead to our muscles, and thus our muscles stop working, with muscle weakness, lack of hand coordination and other parts of the body, frequent stumbling, as we were previously mentioning, and difficulty raising the hands over the shoulders in a more severe type of motor dysfunction. Now, this is more or less the order that we find them. However, a patient, of course, is presenting nerve damage in all of the nerves from the beginning of the disease. Neuropathy, as we previously mentioned in the previous video, is going to often be found in patients with type 1 diabetes mellitus 5 years after the diagnosis, because we already had semi-frequent hyperglycemia events. In a patient with type 2 diabetes mellitus, we are going to find it sometimes at the moment of diagnosis, because we don't know how long the patient has had diabetes, because it was completely a silent disease, as we've previously explained. Now, how can I know I have neuropathy? Of course, the first thing is like a questionnaire. This is the Michigan Neuropathy Screening Instrument. It is a self-completed questionnaire, and of course, on top of this questionnaire, the physician is going to check all of the parts of the body, but mainly the feet, the hands, and some of the muscles and reflexes. But in the questionnaire, basically what we are going to look for is alterations in the sensitive, motor, and autonomic nerves. So here is all of the questionnaire. We are going to score this patient with the number of yeses and nos that he or she gives us, and if the patient has 7 or more, then that patient probably has a diabetic neuropathy. Some of the questions, I am not going to read them all, but for example, are your legs and feet numb? Do you ever have any burning sensation in legs or feet? Are your feet too sensitive to touch? Do you get muscle cramps in your legs and or feet? Do you ever have any prickling feeling in your leg or feet? When you get into the tub or shower, are you able to tell the hot water from the cold water? and so on and so forth, the 15 questions. So once the patient answered the questionnaire, we score him or her with 7 or more. We are going, of course, to make the exploration. We are going to check for the sensitive exploration. So if the patient can detect temperature, vibration, touch, and pain in each of the feet, and of course in the hands, and of course if there are other areas of the body that the patient reports like affected, we are going to do the exact same exploration. Strength and tone of the muscle, so that the muscle is healthy, that it is not like reducing in size, losing muscle mass, it can carry the weight that we need it to carry, the blood flow leading to this, mainly the feet and the hands, the presence of anatomical malformations associated with diabetes like Charcot foot and autonomic neuropathy. And as you might imagine, this is a very thorough exploration that we do of the patients, just focusing on the feet. And here we can see the main points where we are going to check, once again, temperature, light and deep touch, vibration, and so on and so forth. In the foot, we have to check every single one of these points for all of these sensations in both feet, and we are going to check them in a symmetrical way. So we are going to ask the patient if he or she feels any difference, if one foot feels more or less than the other one, if there is some pain, if there is some other thing that shouldn't be there. And of course, once we have the diagnosis, the diagnosis, it is not necessary to make any more studies. We have some studies that might be useful for some patients, like, of course, the electromyography and some electrophysiological studies, even other things like MRIs and other things. This can be, once again, useful in some patients where we are not really certain that the patient has diabetic neuropathy, but in most cases we do not need anything beyond the thorough exploration, of course, interrogation of the patient, the blood studies showing that there is diabetes and that it probably is not very well controlled. And then we, of course, go to treatment. The treatment is going to be mainly about diet and exercise because we want to control the glycemic level in those patients. A correct glucose level is the backbone of the treatment of diabetic neuropathy, because if we give all of the treatments and the patient has hyperglycemia, constant hyperglycemia, the rest of the treatment it is not going to work. It is not going to benefit that patient. It might like cover up some of the symptoms, but it is not going to be able to stop the hyperglycemic disaster that we have in the bloodstream. So once again, the first and most important step for the control of diabetic neuropathy is glycemic control. Once we have that covered, once the patient is properly controlled, the next thing we have to offer our patients is physiotherapy. There are some exercises and some activities that will help with the motor part to protect the muscles in the different parts of our patient's body, and it will help with balance. That is, of course, very important because a poor balance and a patient that is constantly stumbling, of course, can extremely limit the quality of life of that patient. We need to do a fit checkup. This needs to happen daily. The patient has to know how to check his or her feet to, of course, understand when a lesion, an ulcer, or the neuropathy is appearing and how to manage it, manage dysautonomia, and manage pain. This is all going to be part of the treatment of patients with diabetic neuropathy. And finally, talking very shortly about treatment of painful diabetic neuropathy, we will of course have another video going a deep dive into these treatments, but we have three main classes of drugs. Number one, gabapentinoids with gabapentin and pregabalin. Number two, dual antidepressants that work on serotonin but also on noradrenaline or norepinephrine. Here we have duloxetine and venlafaxine, and finally tricyclic antidepressants with amitriptyline and imipramine. These are very good drugs. Not all of them can be combined, but we can combine one or two to have like stronger results. And another type that is not like the pillar, like the backbone of treatment, but it can be used just not so often, are of course opioids, and the best opioids for neuropathy, and specifically diabetic neuropathy, are tramadol and tapentadol. These two are the most suited for a neuropathy because they don't only have the opioid mechanism, but they also have a weak inhibition of serotonin recapture, and this also helps with pain. There are other types of treatments. They are not as used because they are not as useful, especially opioids. For example, strong opioids might provide some relief, but they of course have a very high addiction potential, and they have other complications. So these are like the mainstays of painful diabetic neuropathy, the main ones we use. This is the information for today. Of course, I am going to leave the references so you can learn more about this important topic, and that's it for today's video. So this is it for today's video. I hope you liked it. You understand now a little bit more about diabetic neuropathy, and we can thus prevent it, detect it, and treat it promptly. That is what our patients need. So thank you very much, and as always, help us change the world, share the information.